In this session, we are going to be looking at PEG feeding. PEG stands for percutaneous endoscopic gastrostomy. Hi, I'm Sharon. I'm working as an assistant professor at Tripling College of Nursing. The following are the objectives that we'll be addressing in this session. Do go through. Let's see the introduction and definition. A gastrostomy tube may be used for a patient who requires enteral nutrition over an extended period of time. Gastrostomy tubes can be placed surgically, radiologically, or even endoscopically. Here in specific, we are going to be looking at percutaneous endoscopic gastrostomy, in short form referred to as PEG. This procedure has fewer risks than surgical placement. It is a procedure in which a flexible feeding tube is placed through the abdominal wall and into the stomach. It is an alternative to open surgical gastrostomy insertion, and it does not require a general anesthetic. A mild sedation is what is typically used. Now let's look at the prerequisite for a PEG insertion. The patient must have an intact, unobstructed GI tract, and the esophageal lumen must be wide enough to pass the endoscope for this. Let's look at the indications for PEG procedure. Patients require PEG feeding tube when they cannot eat, digest, or absorb food due to neurological diseases such as cerebrovascular disease, motor neuron disease, namely amyotrophic lateral sclerosis, multiple sclerosis, Parkinson's disease, cerebral palsy, dementia, reduced level of consciousness, head injury, and prolonged coma. Other conditions include psychomotor retardation, patients who require intensive care, cancer, namely cerebral tumor, head and neck cancer, esophageal cancer, and abdominal malignancy, patients suffering with burns, congenital anomalies such as tracheoesophageal fistula or atresia, miscellaneous conditions such as cystic fibrosis, short bowel syndrome such as Crohn's disease, facial surgery, polytrauma, chronic renal failure, HIV and AIDS, and gastric decompression. The contraindications for PEG procedure are serious coagulation disorders where the INR is more than 1.5, PTT is more than 50 seconds, and platelet count is less than 50,000 per millimeter cube. Hemodynamic instability, sepsis, severe ascites, peritonitis, abdominal wall infection at the selected site of placement of the tube, marked peritoneal carcinomatosis, interposed organs, where one organ can be over the other, example liver, colon, history of total gastrectomy, gastric outlet obstruction, if it's being used for feeding, severe gastroparesis, that is, a condition that affects the normal spontaneous movement of the muscles in the stomach, again if it's used for feeding, and lack of informed consent for the procedure. Let's look at the special considerations to be taken into account prior to PEG insertion. A prior abdominal surgery. A PEG insertion can be done after confirming a safe tract with no interposed bowel. In obese patients, PEG can be safely performed with minor modifications even in patients with an extreme body mass index that is more than 60 per kg meter square. In pregnancy, PEG tube insertion may be complicated by potential risks of uterine and fetal injury. However, it is reported safe in up to 29-week gestation with no major complications after applying special precautions. When medically indicated, there is no age or weight limit in PEG tube placement. The safety of PEG insertion, even in very small, that is 3 kg, and medically complex infants, has been determined. Let's look at the techniques of PEG insertion. The first technique is the Gardner-Ponsky technique. Here, it involves performing a gastroscopy to evaluate the anatomy of the stomach. The anterior stomach wall is identified, and techniques are used to ensure that there is no organ between the wall and the skin. The first step is applying digital pressure to the abdominal wall, which can be seen indenting the anterior gastric wall by the endoscopist. The second step is transillumination, otherwise referred to as diaphanoscopy. The light emitted from the endoscope within the stomach can be seen through the abdominal wall. Step 3 involves insertion of a smaller needle into the stomach before a larger cannula is passed. The needle size is usually 21 gauge with 40 mm in length. The last step involves the use of an angiocath to puncture the abdominal wall through a small incision, and a soft guide wire is inserted through this and pulled out of the mouth. The feeding tube is attached to the guide wire and pulled through the mouth, esophagus, stomach, and finally out of the incision. This is how the PEG tube will appear on the outside. The second technique used is the Russell introducer technique. It is a recent approach. Here, the Seldinger technique is used to place a wire into the stomach, and a series of dilators are used to increase the size of the gastrostomy. The tube is then pushed in over the wire. The following are the parts of a PEG tube. The PEG tube has a feeding port cover to cover the feeding port. It has a balloon port to instill air into the balloon, a feed head or a bolster, tubing, stoma length markings so that we know at which point the tube is being inserted, an external retention disc which is close to the skin to prevent accidental dislodgement, and the balloon as discussed earlier, which will also help in proper fixing of the PEG tube. Tube feeding can be given in 3 different ways: using a pump, gravity drip, or syringe. The first picture shows the use of an infusion pump. This is used for continuous or intermittent feeds where the formula is given without stopping over 8 to 24 hours. The second picture shows a gravity drip, which is used to give larger amounts of formula over a shorter period of time, usually 4 to 6 times each day. The final picture shows feeding using a syringe, which is the fastest method where larger amounts of formula are given at a period of time. Feeding using a syringe or gravity drip can also be called bolus feeding. Next, we're going to be looking at bolus feeding procedure. The first step is to assemble all equipment, including the prescribed formula, feed container, drinking water, feeding syringe, and a measuring cup. Hand hygiene needs to be performed and wear clean gloves. The fourth step is to give feed. See the tube feeding plan as prescribed by the treating doctor. In giving the feed, fill the syringe with a set amount of warm water and gently push it through the feeding tube. This is considered as a flush. Measure the set amount of formula into a measuring cup and then remove the plunger from the syringe and attach the syringe to the feeding tube. Pour the formula into the syringe and then hold the syringe higher than where the feeding tube goes in. Let the formula run in slowly by gravity. If the tube is thin, then the syringe plunger can be used to gently push the formula through the tube. Care to be taken to not let the syringe get completely empty before refilling, as air can enter the stomach. Take at least 15 minutes to give feed. After giving the feed, flush the tube with the prescribed amount of water, disconnect the syringe and recap the feeding tube, clean and replace the articles. Then wash hands, document the procedure in the nurse's record. Next, we're going to be looking at the role of nurse. In care of site, assess the site daily for signs and symptoms of infection such as redness, swelling, pain, drainage and strong odor. Small amount of serosanguinous drainage and redness is normal. The site should be cleaned twice daily with saline for the first week, and then soap and water can be used. Keep the site dry between cleansings. Once the first week is over, no special dressing or covering is needed. Inform the patient to protect the tube and site. The next role of the nurse involves the care of the tube. Here, the nurse should see that excessive movement of the tube is prevented, prevent the tube from being pulled out or becoming tangled, try to prevent a blocked tube, always crush the medicines well before giving through the feeding tube, always flush the feeding tube with 40 ml of water before, between and after giving medications, always flush the tube with at least 40 ml of water every 4 hours or 8 hours if overnight. This also helps in preventing the blockage. Always begin and finish each feeding session with a water flush. This keeps the tube clean and stops feed building up inside the tube. Other nursing considerations to be taken into account are mouth care is extremely important in these patients who are not taking in any oral nutrition. Brush the teeth twice daily. Keep the mouth moist with swabs. Even patient can be encouraged to use mouthwash to swish and spit, and a lip balm can be used to avoid chapped lips. The complications post-procedure are divided into two, namely minor and major. First, we'll look at the minor complications. They are wound infection, peritonitis, stomach leakage, inadvertent peg removal, tube blockage, pneumoperitoneum, and gastric outlet obstruction. The major ones are aspiration pneumonia, hemorrhage, buried bumper syndrome. It is one of the uncommon and late complications of PEG placement. It occurs when the internal bumper of the PEG tube erodes into the gastric wall and lodges itself between the gastric wall and the skin. The next is perforation of bowel, necrotizing fasciitis, and metastatic seeding. The following are the references. Do look into it for further reading.